Good morning again, everybody. Thank you for sticking around. Thanks again for Microport hosting. Today, this talk, what I really want to do is try to use some case examples to show how the medial pivot knee can be used through a wide variety of pathologies. So we'll do that starting with some simple and moving on to some more difficult cases. These are disclosures for this talk. I think we all can agree at this point that medial pivot is definitely a usable and beneficial way to do a total knee replacement. But one thing that we want to highlight and start to explore is whether or not the medial pivot also has some versatility and usability in a more complex case, so revision cases, hardware, etc. So we want to stay true to that medial pivot design philosophy, but include a wider breadth of patients that we can utilize it in. So that's important when we think about specific kinematics. So we think we've covered that over and over. But really our objective today is I want to look at the utility of the medial pivot and its design through cases, and then highlight some of the intraoperative flexibility things that I have seen, and maybe you can hear about some tips that you guys may have as well. The Evolution knee portfolio really spans from a simple primary all the way up to a full revision complement. There's patient-specific designs or a utility, and there's also a cementless. All of these, though, highlight a few key things. So they all are bone conserving. I think they all can be utilized in rapid recovery type protocols. They all seem to replicate more natural kinematics. And they seem to have some improved benefits over PS designs. We just talked about that. There's a cement-free nitrix coating, and we know that they have long-term survivorship. So our first case is a pretty straightforward, simple primary total knee, a little bit of varus, a 60-year-old lady, a very active patient who had some metal allergy. So it highlights the first utility that we can use a nitrix-coated knee to help us get around some of that metal issue. This is an ASC patient that was a rapid recovery and did quite well. Similarly, a very simple case here, a primary CS. This is a cement-free design using the Evolution, and again, another rapid recovery patient. So getting to just a little bit more complexity. So a young patient, 54 years old, female, but with a high BMI. So a couple of things that I would consider for me in this case. One, we try our non-operative treatments given the BMI, but she failed those. And then due to that BMI, we want to increase her tibial fixation to try to minimize loosening. But at the same time, we want to try to give her the benefits of a PS knee. When I originally was, of an MP knee. When I was originally doing this, I was doing a lot of PS on the bigger patients. But I found as my technique has gotten a little bit better and my confidence has grown, I think I've started to push a little further for these higher BMI patients, and they do very, very well. The one thing to be mindful of on this is that there's different stem extenders you can use, a 25, 50, and longer. These are cemented stems. This is a 25 millimeter stem extension. The next size up of a 50 can get a little bit, in my opinion, in certain patients, a little bit long, and sometimes has a little bit of push into the metaphysis, and I've had a couple patients have pain from that. So just be mindful of that. It requires one extra step or a slightly different step on the for your tibial preparation, and there's a lot of flexibility through the modular keel, which we'll talk about later. So another patient with some hardware in place. I think we're going to see these more and more commonly as patients start to get through their ACL or previous surgery. You're going to need some total knees. And not removing hardware, I think, is an easy way to improve your OR efficiency and help them through their rapid recovery a little bit better. There's less dissection. And if we can use this MP design to leave that hardware in situ, I think that's better for the patient overall. So this one's kind of putting a few things together. So this is a 72-year-old lady. So she has a remote distal femur fracture, does not have great bone quality as we can see. And so the last thing that I would want to do for her, preferentially, would be take all that hardware out and leave a bunch of holes in her femur. And I think previously I probably would have done this in a staged fashion, taken her hardware out or cut the plate and then worried about a stress riser. But with this design, we can actually use the Revo tibia. We add a little bit of a stem for her BMI, so we get rid of that. We then can use a straight CS femur and leave the hardware in situ. And I used navigation techniques to get around for our distal femoral prep, so that we can actually leave all these components in place. I did do a 3-degree femoral cut, which I think is helpful sometimes in these valgus knees. This is a patient of mine that failed. He was a 69-year-old gentleman. I'd done a total knee with cementless design. He's an avid soccer player, and I think he might have expected a little bit more than I had prepared him for the surgery. He went back to playing soccer. The femur unfortunately got loose, and so we converted him over to a stemmed CS. So just to highlight another option in the portfolio. So it maintains all the benefits of the medial pivot. We exchanged just the femurs. The tibial remained well fixed, and you can cement in then a new femur for that fixation. So this is a quick way to do a fairly easy problem to fix, maintaining the benefits of that medial pivot. The one thing that I would point out is that on this design, the trunnion that comes off of the femur, you can see on the lateral there by the arrow, it's fixed in place. So just be mindful of that when you're positioning and planning out for your femur. This one is, I just wanted to highlight that I previously had been using Stryker, and one of the really things that I did like about the Stryker was the intraoperative flexibility to change over from a PS design over to a TS design or a more constrained design. And MicroPort now has this available in a medial pivot design. So this is a case where a valgus male, 73 years old, a bit of a bigger guy, and I was planning to just use a regular CS knee. Unfortunately, when I got in there, I didn't really feel that I had made the knee stable and felt that we need a little bit more constraint. Doesn't happen often, but when it does, it's good to have a backup. And so in order to convert this over, it's fairly straightforward. You can use your same Revo tibia that you would have prepared for. I replace the CCK trial on, which can come in a separate pan if you want that set up, so it minimizes some OR or maximizes OR efficiency. And you simply place your guide for your stem prep. You cut your box, and then the implant is placed. So there's not a lot of changing things around. It improves our intraoperative flexibility and versatility, and we still get our CCK with the medial pivot. In revision settings, we do have a medial pivot option to consider as well. So this is a patient, unfortunately, of mine that had done really well up to the post-op 1 year mark. We hadn't seen her. She underwent some aggressive chemotherapy, and I'm not sure if that's what caused it, but she did develop right around that time, about 9 months later, a tibial failure with significant loosening. Thought it might have been infection. It was not infected, and so we were able to convert her over to a CCK design. This one I have a cone in, you'll notice, and we'll talk about that a little bit in a minute, but you can use cones with these implants without difficulty, and there's a few tips and tricks about that. She also had some augments added to the tibia, and this one I think we could have done a CS femoral option as opposed to the CCK, so you do have some good variability for what you want to do based on your preference or what the patient desires. Infection cases, a patient of mine, 2-time spacers that had not cleared the infection until the second time, so bone loss becomes a little bit of a challenge. In this one, we use a tibial cone with an offset, and so when you have the modular keel on the Revo tibia, it allows you to rotate that independent of the tibial tray. And this can help when you put when you have to use a cone. So basically, the way that I've been doing it is I place the cone obviously in the defect where it needs to go because that's kind of set. I then will use the keel and rotate it as much as I can into the bone so that it has the best bone contact. And then the tibia can be placed independent of that to allow maximal bone coverage. So sort of a 3-step process so that each part of the implant is doing what it should do, and you're not compromising one off of the other. The overview just for a CCK femur, if you haven't seen it, it's a fairly standard revision system, multiple sizing. We have lots of poly options. There's offset adapters and stem extenders and cemented and non-cemented options. And this all still maintains the benefit of having the medial pivot philosophy and the kinematics just in a more constrained design. The modular keel, one thing to highlight, I think it is an important part of this system. There are 3 sizes, so make sure you have the correct size when you get your tibia. There's about 120 degrees between fins, so a good spread. When you use an augment, you lose some of that rotational ability. You only get about 6 degrees, but if you don't use an augment, you can rotate the keel independent of the tibial tray up to about 30 degrees. And this does help, I think, in certain cases when you're maybe losing a little bit of bone in certain areas and you don't want to do a cone. You can place this tibial keel in a good position. You also can remove the keel if you need to, if you have a really small cone, or using with offset and it just won't fit. There's the ability you could probably do it without the keel, as that's been described. So really, I think any revision that would require anything short of a hinge probably can be done with some sort of medial pivot implant. It seems to be compatible with all porous medical cone and sleeve systems that I can think of. I've tried 3 different companies, and they all seem to work well with it. If you have a stress riser or something like that, don't forget about the stem extenders. They can really give you more variability for how long the stem options can be. And then we can manage periarticular deficiency or deformities using augments and offsets. When you just look overall at the competition, I think that this overall portfolio system offers a lot of benefit while maintaining all the flexibility, capability, versatility, usability, and importantly, the kinematics that we've highlighted so well the last couple of days here. So for me, I really transitioned over in 2016 using Medial-Pivot initially in baby steps, and then 2018 for basically all my primaries and some revisions. And since 2020, I really have gone to the Medial-Pivot for virtually all of my cases, whether that's a revision or a primary. And I do utilize those TM cones when we need to, or the case calls for it. The instrumentation is slowly improving, and I think this, as we get better with how to use that instrumentation, the intraoperative flexibility will also improve, and we'll really have a complete system that can really help with all knee pathologies. So just in summary, I think Medial-Pivot design is well established. I think we know it offers good longevity in primary total knee. I think with the Evolution knee portfolio, we can treat a wide variety of conditions, all while maintaining the kinematics that we desire. And then as we get better with our intraoperative flexibility and knowing some of the different ways to use these revision implants, I think we're going to have better real-time decision making and hopefully a wider variety of treatments, or excuse me, pathologies that we can treat. Thank you very much.